One of the largest contact tracing studies in the world to date has been conducted recently with coronavirus positive patients in the states of Andhra Pradesh and Tamil Nadu. They have thrown up some very interesting and surprising results, which gives us an insight to how the disease has been spreading and what are the particulars of the spread in India. Let me just take you through a few of the highlights. Well, one of them is that super spreaders are real, and in fact just 8% of those who have contracted coronavirus are responsible for 2/3 of the spread in India. The second big finding, of course, is the role of children, those under the age of 14, who are seen as silent spreaders and end up spreading COVID to their peers and to their families without showing too many of their symptoms. A third very key point is how the mortality rates are higher in India, specifically for those aged between 40 to 69 years. Now, these studies have been done along with the state governments of Andhra Pradesh and Tamil Nadu and helmed by the CDDEP. The director of the organization, Dr. Ramanan Laxminarayan, joins us now for more on the study. Dr. Ramanan, pleasure to speak with you on ET Now. Can you take us through what are the real big insights which were eye-openers from this study?
So Tamanna, this is not just one of the largest, it's the largest contact tracing study of COVID epidemiology in the world by a long shot. In fact, the previous largest study was only about 1/12 the size out of South Korea a few months ago. And so it is a really incredible study, which is possible by the work of tens of thousands of health workers in Andhra Pradesh and Tamil Nadu. So it was really their hard work that made it possible for us to have a study like this. So let's start from the beginning. In this study, we had data on about 80,000 primary cases. So people who were tested for COVID, and they tended to be more in the age group of sort of young adults, somewhere between 40 and, 20 to about 50 years of age. And we had data on about 575,000 contacts. We actually had data on millions, but these were the data that were of good quality that we had, all of their parameters on. And what we found was that, the secondary infections, 60% of those secondary infections were caused by just 8% of the primary cases. But we also found that 71% of these primary cases did not seem to transmit the virus to anybody at all. So the vast majority of people with COVID don't seem to transmit the virus at all. Few people transmit a lot. That's number one. Second, we found that children were playing an active role in the transmission, although the numbers of children were smaller in terms of how many were tested. Remember, everyone in the study has been tested for COVID, they were both receiving COVID from adults, 20 to 50 year age group. They were also transmitting very actively to their own age group, but also to people across, the population. So they seem to play an important role in transmission. Again, these two findings are not surprising for respiratory pathogens. We see these for other respiratory pathogens as well, but we have never actually observed these in such a large data set for COVID. So there's been a lot of confusion in the case of COVID, say, for instance, on the role of children, where in many countries, they don't believe that children play an important role, but the evidence seems to suggest otherwise. Israel, for instance, they had opened up their schools, they had a big second wave, and now they've shut down their schools and they've gone in for a second lockdown in Israel. So this is happening in other parts of the world as well, but it's good for us to have these data. Now, the third thing is mortality. We find that a lot of people, in India die in the younger age group, 40 to 70. The case fatality ratio, which is proportion of people with COVID who die, is higher than in the US, China, Italy, or Brazil. And that's probably because there's a lot of undetected hypertension and diabetes in that age group. We also find that people in the older age group of 80 plus die at a lower rate in India. And that's because what we call a survivorship bias, which is that, people who have already reached that age must be fitter or stronger in some ways, and therefore they don't die as often. We also find that the lockdown has been quite effective. Prior to the lockdown, we saw that, the reproductive number is about as high as 4, which means every primary case was creating 4 secondary cases. And since the lockdown, that number has come down to about 1.5. So if anyone wants evidence that the lockdown made a difference, there is very clear evidence from this study. And the additional benefit has been that every month later that you catch COVID, your chance of survival is increasing all the time. And that is probably because the quality of medical care, clinical guidelines, medical research, all of this is enabling doctors to keep people alive much better today than they would have managed to do 4 months ago had we not had a lockdown and we'd seen a peak in infections. So I think a lot of the studies' evidence points in support of that lockdown at the early stage. There are many more results. I could keep going on, but this is what is possible because of the massive amount of data that has been collected by these two states.
No, I want to understand a little more. I want to understand a little more, Dr. Ramanan, about the super spreaders. Is there any distinctive feature of people who end up spreading more than the others? Is it just a function of how much they go out or where they go? Is there a particular age group or any more detail you can share about super spreaders?
So that's a great question. At this stage, we don't know that just yet. That's more work to be done on the characteristics of super spreaders. But what we do know is that there's no systematic, there are two things that define super spreading. One is some people just shed virus more. Shedding virus is they transmit the virus more. They may not be symptomatic. They may be asymptomatic, but still, because of their host factors, their biology, they tend to shed virus more. Second is that some of these people also happen to be in situations like there might be, a shopkeeper in a busy market or whatever, that they have the opportunity to transmit the virus to many more people. It's a combination of these two, which is the biology and the environment that causes super spreaders. Currently in our data, we don't have the ability to separate out this, but we are working on it. I think this is where we'll go to next in this set of questions we asked.
How does this, data and these findings fit in with what India is doing right now? You talked about the efficacy of the lockdown. We are in a very aggressive unlock kind of phase, and for reasons you and I have discussed several times before, there's no other way through it. For example, now states can decide if they want to open up schools with parental consent after October 15th. So children may be going out in larger numbers again. Cinema halls, restaurants, malls, pubs, etc. Everything is opening up. How does this data sit in with what is actually happening right now?
I think these data have to be used to have a smart unlock. If we just went back to the pre-lockdown phase, we would be facing a lot of difficulty. I think what we should recognize is that, for instance, in the study, we found that coming in contact with someone who's COVID positive in the community carries a very low risk of infection. It's a 1 in 40 chance of infection. Coming in contact with an infected person within your household is a 1 in 10 chance of infection. But coming in contact with someone who you're traveling with for 6 hours or more in a very closed environment is the highest risk of infection. There's an 80% chance of infection. So I think people need to calibrate their risk based on what we're now finding, which is that traveling with someone for 6 hours, COVID positive, that poses the greatest risk. Going out into the marketplace and coming in contact with someone who's COVID positive is a much smaller risk in comparison. So I think that the unlock phase has to take evidence into consideration. Not all risks are the same. Outdoor is infinitely better than indoors. It's better not to have indoor dining if it's possible because dining, masks off in an enclosed space, that's challenging. Dining outdoors, not a problem. The vast majority of so-called eateries or restaurants in India are open air or, they might be dhabas which are outdoor. They don't pose much of a risk at all. I think lumping all of them into one category is really not the thing to do, which is enclosed air-conditioned restaurants perhaps face a much greater risk. And I think children going back to schools, we have to do this much more smartly. Going back to the same kind of situation where we put a lot of kids in school buses and send them to schools together, that may not be the best idea given not just the study. And remember, the study is one study. It is large, but this has to be replicated with other studies with more evidence. So that's how science works. But what we would guess is that we might want to stagger school so that some days some children show up, other days some other children show up. We have to be creative and thoughtful. And it is not like we did this before COVID, now we're going to go back to that world, right now. I don't think that makes a lot of sense. We can be a lot smarter about what we're doing.
So when are we going to go back to that world? I think that's the one question in everyone's mind. Will a vaccine change it? Will herd immunity change it? What will change? When will it change? Are there any clues to that very, very difficult question from your study?
No, I don't think our study informs any of those questions at all. Those are very difficult questions to answer because I think for the foreseeable future, it's not a vaccine that's going to make a difference. It's going to be our behavior and how we retool our systems. And remember, we've always made changes in our lives in response to a risk. We make changes to our lives in response to the risk of car accidents. We wear seatbelts, or we have safety measures on aircraft. We have all sorts of things that are for our safety. And I think to some extent, the mask wearing has to be part of our safety apparatus for some period of time going forward, until there is a safe, effective vaccine or we reach population immunity. I think both of those are possible. I don't know which one will come first. It's possible that the population immunity comes well before a vaccine for India, especially. And it is possible that we get out of this in 2021 as well itself. But I don't think we can answer those with this study. I think this study is primarily aimed at understanding the situations in which COVID spreads. And these are not India-specific situations, right? These are situations that, children interact with other children the same way in Japan or Korea or Israel or the US, the same way that Indian children interact. It's hard to get children to not keep away from each other if you send them to school together. You can't enforce mask wearing and social distancing in children. It's just impossible. Anyone who thinks that has obviously never observed or had a child. So I think we need to be pragmatic here, but it's going to be a bit of a long haul still.
No, so as one parent to another, and I'm sure many people watching this are also parents. So you're saying no play dates, no interactions, and of course no school for some time till we know that children can be safe.
No, I'm not saying that there's no play dates. All that I'm saying is that be cognizant of the fact that if children are interacting with other children, that that you have at least have a some mask wearing or something which is preventing the transmission. You have to balance a lot of risks off against each other. But I would say that situations where a lot of children are crowded into indoor spaces which are potentially air conditioned, that is probably not desirable. But one-on-one or one-on-two interactions are perfectly fine, particularly if you know for sure that that family does not have a COVID case. That's not a problem. And then again, calibrate your risk to the person who's in your household. If you have an elderly person in your household, you might want to be a little more careful. If you don't, then you can be a little less cautious from that perspective. We have to come back to some semblance of normalcy, but we have to do that by paying attention to this kind of evidence. And I think schools are going to have to recalibrate, to be honest, Tamanna. I don't think you can put children, 40 to a classroom for the foreseeable future. We might have to do something like staggered hybrid classes, which is what many other countries are doing, which is do your online also, but also do, in person, so that half the time they're in person and the other half, so that you have only 20 kids in a class at any given point in time or something like that. It is going to have to be situations like this.
Yeah. Well, bizarre dystopian situation for our next generation, but it is what it is. Thank you so much, Dr. Ramanan, for speaking with us and sharing these very crucial insights coming from this study.
Thanks for having me.